It's my pleasure to invite Dr. Chitra Andrew. She'll be speaking on fetal challenges in ART pregnancies. Dr. Chitra obtained her MBBS degree from Government Kelapuk Medical College, Chennai. Then she completed her MD in obstetrics gynae from Sri Ramachandran Medical College, Chennai, for which she was awarded the gold medal. She trained in obstetric ultrasound at Mediscan Systems 2008. She worked as faculty in Sri Ramachandran Medical College, Chennai since January 2001. She is working as an associate professor in fetal medicine unit, SRMC, since 2008. Currently, she is attached as a fellow in fetal medicines at Mediscan Systems, Chennai. So I welcome
wish to say to you this morning. Professor Suresh is a fellow of the Royal College of Obstetrics and Gynecology. He is credited with have established Mediscan as the first ultrasound and training center in India, with over 3,400 doctors as alumni now. He has established fetal medicine as a specialty in India, and Mediscan was recognized by FMF UK as the first fetal medicine training center in Asia. He established the BDRI, of which I think some of you may be members. He manages Mediscan Systems, Surendra Genetic Laboratory, Perkin-Elmer, and also volunteers at the Voluntary Health Service in Chennai. And he is a visiting professor at the Fetal Medicine and Perinatology Unit in Ramachandra Medical College, Chennai. Today we are talking about fetal challenges in ART pregnancies. Consider the story of Mrs. X. It could be anyone. 36 years old, married 15 years, finally conceived after IVF. The management of her pregnancy would vary immensely depending on who is her obstetrician, but in many cases it would mean strict bed rest for the whole duration of the pregnancy. She would never be allowed to leave bed. She would be dependent on her family for basic life activities, cannot walk, cannot sit up and eat, and probably by the end of pregnancy is deeply depressed. So yes, IVF pregnancies are different. But why? From our point of view, starting from early pregnancy, there's the hurdle of ectopic pregnancy and the responsibility of establishing the number and chorionicity of the fetuses. In the first trimester, we have screening challenges and sometimes the need to do a fetal reduction. In the second trimester, anomalies, and in the third, if we get that far, growth restriction and obstetric complications. So they are different because the laboratory processes that are involved in creating this pregnancy are expensive, meaning that each pregnancy becomes that much more precious. Maternal age, being advanced, poses its own medical problems, and in addition, pregnancy unmasks the problems that these women may have developed a few years later. Adding on top of all this, multiple births means that the obstetric and perinatal risk is increased immensely. So this study shows that where we compare ART with natural conceptions, the rate of congenital anomalies, spontaneous preterm birth before 37 weeks or before 32 weeks, and low birth weight less than 2.5 or very low birth weight less than 1.5 is all simply doubled when compared to natural conceptions. If we look at the first trimester risks, there's the fear of spontaneous miscarriage, of ectopic pregnancy, of heterotropic pregnancy and ovarian hyperstimulation. So this means that these women are subjected to more frequent early pregnancy scans. Spontaneous miscarriage has very high rates after ART, and in women over 40 years, the spontaneous abortion rate is said to be about 30%. Ectopic pregnancy, again, has a 2.5 to 5-fold increase over natural conceptions. Although I'm sure many advances have been made and things like dummy transfer and the volume of fluid instilled has been changed and studied in great depth in order to reduce these complications, Still, we need to be aware that they can happen. Again, cornwall pregnancy also shoots up to 2 to 4%. Heterotropic pregnancies, again, are much more common in ART conceptions. So whereas in any other pregnancy, one may think that we may see a heterotropic pregnancy maybe once in an entire career, here, after finding 1 or 2 or 3 heartbeats inside the uterus, we need to make a very careful search to see if there are any more outside the uterus. And this mirrors the dramatic increase in multiple gestations after IVF due to the transfer of multiple embryos. Ovarian hyperstimulation has been dealt with in great depth yesterday and this morning. So I will just confine ourselves to the things that we see on ultrasound and monitor, such as the ovarian size, the free fluid, ascites, sometimes requiring TAP, pleural and pericardial effusion, while other monitoring goes on for DIC, electrolyte imbalance, and assessment for need for ICU care. So after having crossed with great difficulty the first 10 weeks of pregnancy, we can heave a sigh of relief and then pick up our courage to face the next set of problems. This comes in the shape of the first trimester screening. This is an opportunity for us to evaluate these fetuses with regard to their crown rump length, their nuchal translucency, and to make an early search for anomalies. Certainly, at this stage, we will be looking at both the limbs, the spine, the head, to evaluate the CNS, and to look at the mandatory anatomy as has been prescribed by the guidelines. In addition to all of this, we would like to do the biochemical markers, but in all of this, we might still find an increased nuchal translucency or an unossified nasal bone, putting up more problems that we have to deal with. In IVF pregnancies, in this large study, which was attempting to study the effects of factors like maternal complications and IVF pregnancies on first trimester biochemical screening, they found that the beta HCG and the PAPE are quite altered in IVF pregnancies. Beta HCG goes 9% higher and PAPE 10% lower. We all know the trisomy 21 risk on software prediction goes up with a higher beta HCG and goes down with a lower PAPE. So false positives can occur. So when we send a patient for a first trimester screening, it is very important that we inform whoever is doing the screening that this is an IVF conception. Again, if we use a donor egg, we need to use a donor age. This sounds very simple, but being in a referral center, quite often we are told that due to confidentiality reasons, the donor age cannot be disclosed. A simple coding, such as patient age, so much, bracket D is equal to something, would help us to overcome this and to give the proper age for biochemical screening and thus reduce false positive or confusing results. NT risk does not change at all from non-ART pregnancies, but we must adjust the first trimester biochemistry for ART and ICSI. And first trimester is the point at which chorionicity must be established with absolute certainty. It's a job that must be finished at this stage. And this will make an impact on not only the maternal biochemistry for us to evaluate risk, but also will help us to plan how to monitor these pregnancies further. So the confounders here are that if we forget the donor age or if we forget that it's an ICSI pregnancy when we're filling out the form, it will increase the risk of invasive testing in this subgroup with a very precious pregnancy who will be averse most definitely to the risk of invasive testing. Multiple pregnancies are something that conferences like this are trying to reduce. They are substantially increased in IVF compared with natural conception. We all know that. And with multifetal pregnancies comes the problem of preterm births and growth restriction. In our own data, we have found that about 68% of our multiple pregnancies are due to IVF, and a good 20 to 30% are due to ovulation induction. We have found that with clomiphene, we even get quintuplets and hexaplets, probably due to non-protocol based approaches. So the frequency of monozygotic multiples also goes up from about 0.4% to about 1 to 5% of pregnancies. And monozygotic multiples, as we know, carry their own complications and difficulties. So while looking at aneuploidy in twins, we would find that monochorionic twins have a higher risk for structural defects due to unequal splitting of the cell mass. But the risk of aneuploidy in the pregnancy is the same as that for singletons. Either both fetuses are affected or both are unaffected. It is very rare to find monochorionic twins who are different genetically. Very, very rare. Dichorionic twins have a risk of aneuploidy that doubles because we have two fetuses and therefore each carries their own risk. But the risk of both fetuses being affected is low. So if we're in a situation where we need to do an invasive procedure, the query comes, is it CVS or amnio? Definitely we would opt for two separate entries if we wish to sample both fetuses in order to avoid contamination of the sample. In a dichorionic pregnancy, we would prefer to sample both fetuses if there is a query regarding aneuploidy. But sometimes the parents would opt that they would prefer to terminate the one showing physical abnormalities and simply sample the one that is left behind. Some would opt that they would sample the affected one, see what the result is, and then decide. So this would really fall upon the situation that is decided upon after counseling. In a monochorionic pregnancy, sampling one would suffice because both are karyotypically similar. With regard to higher order multiples, we have seen in our own data over the past 15 years that the number of cases per month has shot up dramatically, mirroring the trends of IVF. So with regard to fetal reduction, the concerns are that there is an increasing gestational age, there's a decreasing gestational age at delivery with increasing number of fetuses, and there is therefore the higher incidence of preterm birth. But also, we have to consider the ethical and moral issues involved here and the feelings of guilt that the parents carry due to the reduction. The goal, of course, is healthy, live, take-home babies. So who are the stakeholders in a fetal reduction? There's the family who wish to take home babies which are live and healthy. There's the cost implications always hovering at the background. There is the need for IVF specialists to give, in the first place, a pregnancy in very difficult circumstances. And then there is the role of the fetal interventionalist, the doer of the feticide. So we are in a paradoxical situation, an intruder in the happy scenario where a feticide needs to be talked about. Looking at our own data over the past 15 years, we have found that while breaking up the pregnancies into, by way of number of fetuses, the number of twins has increased dramatically. We don't worry so much about twins as we do about triplets. The numbers have also parallelly increased, and these pose a higher risk of preterm labor. We also do have numbers of higher order multiples, and while they are small in number, each of them constitutes a high risk and a series of problems with fetal reduction. So the 6 steps of fetal pregnancy reduction include the decision, evaluation, counseling of the patient, the timing of the reduction, technique, and follow-up. The decision is based on the patient's preferences, But we do have to tell them that triplets or more carry a higher risk for preterm birth. With triplets, the risk is about 21%, and with quadruplets, it goes to 30 to 40%. So not only do we want these babies alive, we want them healthy, because they will be spending a substantial time in the NICU if they come out too soon, and then we have other difficulties there as well. Evaluation would include the number of fetuses, the sizes as determined by crown rump length, the chorionicity, and any abnormalities we may find, and accessibility. During counseling, we tell the patients about the 5% procedure-related fetal loss 1 week post-procedure. They need to understand that there is a chance of post-procedure bleeding or fluid leak, and there could be chorioamnionitis, whereas the risk of serious maternal complications is quite low. We also need to tell them that the inherent risk of fetal loss is more with increasing number of fetuses, and also with the history of previous bleeding or subchorionic hematomas. And also they need to understand that doing the procedure reduces the risk of preterm delivery but does not eliminate it altogether. We also need to understand the sensitivities of the couple. Quite often we do find couples who say it's all very well, but we will carry all these pregnancies, all these fetuses together, and we'll see what the outcome is, and we need to respect their choice and help them through with the pregnancy as they wish to continue it. We need to help to remove guilt feelings. Quite often we do find the women breaking down on the table post-procedure as they see the fetal heart, and we need to speak to them to help them understand that they are doing it for the good of the fetuses which are left behind. With regard to timing, we would optimally place it at the 11 to 14 week period, because prior to that there is a substantial loss of pregnancy, so we'll be unnecessarily doing procedures if we intervene before. And NT gives us an opportunity to choose. Also, with the bringing forward of the targeted scan into the first trimester, we can look at more and more anomalies, and that will help us to choose the fetus a little better. So around 11 weeks would be the optimal time to evaluate and plan the procedure. Because we use a transabdominal approach, the fundus is generally, the fetus closest to the fundus is generally the one we would choose to terminate if all fetuses are equal. But there's no change in the outcome of the pregnancy with the choice or the geographical location of the fetus. While evaluating the fetuses, if we were to find an increased NT or a finding like an omphalocele or a ventriculomegaly, as in these pictures, or other findings such as an encephalocele or a spina bifida or a cystic hygroma or dilated bowel loops, it would help us to choose the fetus which would need to be terminated, or an anencephalus here. But in many cases we find that all three fetuses are otherwise structurally normal, in which case the fetus with the smallest CRL and the sac with the least liker, which is likely the one that would give trouble later on, would be the one chosen. Again, with regard to chorionicity, we have two options. One is to reduce the singleton and leave the twins. Certainly many parents would prefer this because they would like the choice of having two identical babies with all its attendant pleasures. But the risk of TTTS, which is about 25 to 30%, needs to be explained to them. And the other option is to reduce one of the MCDA pair, in which case both of the MCDA will have their fetal heart stopped within 24 hours. And after that, we carry forward as a singleton. But again, the burden on the parents to know that they had 3, reduced to 2 and became 1. And then if there is that small loss of the small percentage of loss of the third, then they are left with no fetus at all. So both are unpredictable with regard to the outcome. So the choice of fetus would be the one nearer the fundus, the smallest, the most abnormal looking, the one with the increased NT, or the MCDA pair. The technique employed includes the use of a 22-gauge long spinal needle. Transabdominal approach is used. Potassium chloride is instilled after the needle position is confirmed as an intracardiac location. Absolute sterility is a must, as has been spoken of this morning. We do not use antibiotics prior to procedure. We do not use tocolytics, uterine relaxants, or progesterone. In a few instances where patients have fever or have come with some other problem, then we may consider antibiotics, but none of the other three are utilized. The final number post-reduction. There are studies showing that reduction to singleton would give the highest take-home baby rates, and also the gestational age at delivery increases. But reduction to twins is most common. The reasons being the uncertainties of anomalies at 11 to 14 weeks, and the fact that concordant anomalies are quite rare in DCDA pregnancies. So twins as the final number is preferred. In our own data, over the last 1 year, we looked at the 410 pregnancies which had undergone fetal reduction, of whom 295 were contacted on phone successfully. And among those, we just stratified the ones who responded to see what we had done and what the outcome was. This is just a breakup of those who had had reductions to either 2 or 1. You'll see that our reductions to 1 are very, very few in number. And these are mostly when we have monochorionic pairs or when we have associated maternal complications. The reduction of twins to singleton is extremely debatable. It would happen perhaps if we had maternal risk factors. So if we have someone who's 45 years old and who's already diabetic and hypertensive and has an IVF pregnancy, we know that carrying forward with twins is going to be a Herculean task, so we may consider it a reduction. But otherwise, a reduction from twins is really not something that we would advocate. And there are, of course, social, ethical, and moral issues involved here. Genetic testing is not done prior to fetal reduction, except in very rare cases where we have advanced maternal age and donor oocyte has not been used. Parental chromosomal translocations, which would mandate genetic testing in everyone anyway, regardless of whether IVF or not, and the presence of Mendelian disorders. So testing is considered only under special circumstances. We do not, as a routine, do testing prior to reduction. Follow-up of these pregnancies after reduction is vital. Targeted imaging at 20 to 22 weeks and then follow-up thereafter, depending on whether they are twins or singleton, is very important. So the outcome of multifetal pregnancy reduction depends on the starting number of fetuses, the end number of fetuses, the care taken during the procedure, and the gestational age at reduction. But overall, the maternal risk factors which are present already will determine whether these fetuses carry forward and to what gestational age they carry forward. Pregnancy outcomes, again, this is the data I was talking about a while ago. Looking at TCTA reduced to twins, out of 207, we had an 81% carry home baby rate of 2 and an additional 12, an additional 6, 6% one baby taken home. In the quadruplets to twins, out of 40 patients, 60 had a take-home baby rate of 60, and an additional 10 had a single baby. And in reduction of quintuplets to twins, 75% had a take-home baby rate of twins and an additional 12.5 of one. So overall, our take-home baby rates are about 85% and comparable to that of other studies. But is this an avoidable procedure? Yes, and certainly I think that is the thrust of conferences such as these, where we are talking about lighter stimulation regimes and the hope of less embryos being transferred. So moving on, now that we have crossed the 11 to 14 week stage, we move on to the second trimester. Anomalies in ART pregnancies are said to be more, and while the absolute risk of having a child with a congenital anomaly is low, the risk from the population baseline of 2 to 4% goes up. So this study was done and published 2-3 years ago, and it shows that among 303 IVF multiple gestations, the major anomalies were seen in 28, that is about 9.2%, which is very high. And in 10.6%, they had growth restriction. In a larger study, they found that the birth defects in offspring conceived with ART, it did increase, the relative risk being 1.3, and birth defects were seen in all major organ systems, CNS as usual being the commonest, and there was no significant difference between IVF and ICSI pregnancies. So in the second trimester, we need a targeted scan which is of high quality and is performed by an experienced operator. Certainly in these circumstances, we must realize that the high BMI of the patients involved sometimes, and the fact that these are multifetal pregnancies, twins at least, would mean that imaging becomes more difficult and the chances of missing out also increase. And if the patient happens to be a diabetic, we need to remember that an echo would be mandatory at this stage. So a careful scanning for anomalies would be mandatory at the second trimester. Genetics and imprinting disorders can also happen, and the association of IVF with Beckwith-Wiedemann syndrome is well known. However, the absolute risk is very low because it is a 6-fold increase, but it's against a background incidence of 1.3 in 1 lakh pregnancies, which is quite low. So yes, we do realize that this can happen, and we would watch out for omphalocele and overgrowth, but in reality, we may find that this hardly ever is a practical problem. Other obstetric complications that can occur in the third trimester and onwards: placenta previa, abruption, hypertension, and diabetes. Looking at this large number of IVF pregnancies, 13,500 IVF pregnancies, and comparing with 5 lakh non-IVF pregnancies, this study in Sweden found that the risk of placenta previa went up, abruption went up, GDM, and preeclampsia. So yes, all these complications do go up about 2 to 5-fold, depending on which we are dealing with. So placenta previa has a 6-fold increase in this study, and this study in fact did 1,349 pregnancies of the same woman conceiving with ART and spontaneously conceiving. They sifted through all their data and looked to see if there were patients who had spontaneously conceived pregnancies and ART pregnancies, and found that yes, there was an increase. And regarding preterm births and small for gestational age, there is a 2-fold increase in preterm births and low birth weights in singleton pregnancies post-IVF. So there's a higher risk of preterm birth and low birth weight compared to spontaneously conceived pregnancies. So here again, singleton pregnancies, singleton from multiple after either vanishing twin or reduction. And with twins, all these show an increased rate of preterm birth and low birth weight, more so as the number of fetuses goes up. So with twins, it goes up to about 60%, and with triplets, it goes to about 90%. Another study looking at only singletons born after IVF showed that primiparity, smoking, and high BMI were linked to very preterm birth. And again, maternal age, primiparity, smoking, and years of infertility were the causes for small for gestational age babies. So this would also indicate that not only is the technology, it is the fact that these patients are by themselves otherwise physically and medically difficult patients, which is why IVF was required in the first place. So those basic physical factors carry forward and cause pregnancy complications in these women. So are ART pregnancies special? Certainly they are, with a higher risk for multiple pregnancy, a higher risk for anomalies, obstetric complications, and then neonatal complications like preterm and growth restriction. So what do we do with this situation? It would take a special group of people working together as a team. The ART specialist, the fetal medicine specialist, the obstetric team, and the neonatal team and NICU to deal with these complications and give a live take-home baby, which is ultimately our goal. Thank you very much.
Thank you, Dr. Chitra. It was indeed a lovely presentation in which you have very nicely explained to us the challenges that a fetus faces in ART pregnancies. Any questions?
Take the mic, please.
Anomalies in one of your slides?
I did.
No.
I didn't say I beg your pardon?
She said no. She said same.
I don't think so.
Okay, maybe then I'm mistaken.
For aneuploidy, I was trying to say that for filling the form, we need to mention that it is a ICSI pregnancy, bar an ART pregnancy, because the algorithms used for calculation will be different.
Oh, I see.
Because while looking at all IVF pregnancy versus all spontaneous conceptions, all these people have higher beta HCGs and lower PAPase. So we'd have to use a different formula for calculating for IVF pregnancy as opposed to a spontaneous conception.
So why do you want ICSI? Because you believe that the aneuploidy is much more in ICSI?
No, because they all naturally have higher levels, so they have to be calculated with a different algorithm.
You're making a distinction between IVF and ICSI.
No,
you're not.
No. For instance, we tick off in the column, right? Whether they are from this ethnic background or that, whether they are smokers or not, whether they're obese or not, diabetic or not. So specifically here, we would look to see whether they are IVF pregnancies or not, because a different algorithm would be used for calculation.
In our center, we are doing fetal reduction between 6 to 8 weeks. Here, the technique is very easy, mechanical destruction, and the percentage of abortion rate is very low when compared to the advanced pregnancy. Except we may miss the abnormality, but we never had any fetal abnormality in these cases.
Point is well taken, but in our center, we would prefer to screen the babies at the 11th-week stage and then carry forward the
How are you doing it 6 to 8 weeks? You're doing a transvaginal fetal reduction. How are you doing it?
Mechanically,
what
we
is
introduce
mechanical?
the needle into the heart and
Okay.
see if the fetal heart is stopped, and then we just remove the needle.
So I think one can analyze the numbers and see how it goes.
The only techniques that I have seen for fetal reduction or done are either transvaginal or transabdominal. This is something new, so we'll have to. I have not heard about that. Instead of injecting KCL, you are just. She's destroying the probably mechanically. I don't understand.
We just put the needle inside the fetus and target to the heart, and we just try to manipulate the needle in the same position for 1 or 2 minutes, and fetal heart stops, and we don't even suck, we don't even disturb anything, and just remove the needle after saying fetal heart is stopped. Normal oocyte pickup needle, transvaginal.
Literature-based evidence?
Sorry?
Do you have any literature-based evidence for this, for your procedure? Do you have any evidence for this procedure that it has been used scientifically before?
Yes, I have read in some of the papers. Long back, about 10-15 years back, it has been published.